Hello, my name is Caroline Oleo. I'm an obstetrician, gynecologist, and I'm going to take you through trauma in pregnancy and intimate partner violence. Under trauma in pregnancy, we shall look at the epidemiology, pathophysiology, the physiological and anatomical changes that occur during pregnancy, and their implications in the management of trauma in pregnancy, management of the injured pregnant woman, and the common complications seen in the injured pregnant woman. Under intimate partner violence, we shall look at the epidemiology, the indicators of intimate partner violence, and some screening questions for intimate partner violence. Motor vehicle crashes account for 60% of blunt trauma in pregnancy, followed by falls that account for 22%, direct assault that accounts for 17%, and other causes that account for 1%. This epidemiology is looking at the global context and is not specific to our country. There are major physiologic changes and anatomical changes that occur during pregnancy to accommodate the growing fetus or embryo. These changes do alter the pattern of injury and the physiologic response to injury in a pregnant woman. Always remember that there are two patients, the mother and her baby, and the best initial treatment for the baby is optimal resuscitation of the mother. These patients have a higher risk of complications, and the most common is premature delivery, abruptio placenta, and fetal death. Always manage these patients in consultation with an obstetrician and surgeon who should be involved in the care of these patients early enough. So let's start off with the cardiovascular system. The plasma volume increases by 50%. There's also an increase in the red cell mass. However, the increase in the red cell mass is not proportional to the increase in plasma volume. This leads to dilutional anemia and a reduced oxygen carrying capacity. Also, the signs of shock due to blood loss appear late. Before a pregnant lady, shows any signs of shock, she will have lost a minimum of 1,200 to 1,500 ml of blood. The heart rate is increased by 15 to 20 beats per minute. The cardiac output is also increased by 40%. However, the cardiac output is significantly reduced by pressure of the gravid uterus on the inferior vena cava in ladies who are 20 weeks of amenorrhea and above, who lie supine or who lie supine for a prolonged period. The changes in the heart rate and cardiac output imply that there will be increased cardiopulmonary resuscitation demands. The uterine blood flow accounts for 10% of the cardiac output at term, which is a potential for rapid massive hemorrhage in case of either direct trauma or blunt trauma to the uterine vessels. The systemic vascular resistance is decreased, which leads to sequestration of blood within the veins during cardiopulmonary resuscitation. The arterial blood pressure is decreased by 10 to 15 millimeters of mercury, which leads to a decreased reserve. The venous return is decreased by pressure of the gravid uterus on the inferior vena cava, which leads to increased cardiopulmonary resuscitation circulation demands. There is an increase in the concentration of most clotting factors. The ones that we are specifically looking at are fibrinogen. The fibrinogen levels are increased, and there's a reduction in the fibrinolytic activity. The other clotting factors which are increased are factors 7, 8, 9, 10, and 11. And there is a decrease in the anticoagulants, that is protein S and antithrombin 3. This means that pregnancy is seen as there's an increased tendency for thrombosis in pregnancy and also in these patients. Under the respiratory system, the respiratory rate is increased. The residual capacity is decreased by 25%. This is because of elevation of the diaphragm. The arterial partial pressure of carbon dioxide is decreased. This is because of the raised respiratory rate. So the changes that are seen in the respiratory rate, residual capacity, and the arterial partial pressure of carbon dioxide imply that there will be decreased buffering capacity, and acidosis will be more likely in these patients. The oxygen consumption is increased by 20%. This is because of an increase in the metabolic rate, which means that hypoxia will develop more quickly in these patients. Laryngeal edema. These patients also have laryngeal edema, which makes intubation difficult. They do have mucosal congestion, which is a predisposition to bleeding in the air. The gastric motility is decreased, and the lower esophageal sphincter is relaxed. These two imply that there's going to be an increased risk of aspiration. These patients should always be managed as patients with a full stomach. The uterus enlarges as the gestation age advances, and we talked about the elevation of the diaphragm in the previous slide. So the elevation of the diaphragm reduces the residual capacity and makes ventilation more difficult. Also, when the uterus or the gestation age is 20 weeks and above, autocompression by the gravid uterus causes supine hypotension. It reduces venous return and significantly impairs cardiopulmonary resuscitation. The heart is also rotated to the left, and on ECG there will be left axis deviation by up to 15 degrees, and this is normal in the third trimester. Other changes that are seen on ECG are inverted T waves, which are seen on LEADS 3 and AVF. There is an increase in the neck and mammary fat levels, which makes airway management difficult. The pelvic vasculature is hypertrophied, which is a potential for massive retroperitoneal hemorrhage in case of a pelvic fracture or uterine trauma. The bowel is displaced superiorly, which is a potential for complex and multiple intestinal injuries in case of penetrating trauma to the upper abdomen. The bladder is displaced anteriorly and superiorly by the uterus, which means it is displaced from the pelvis into the abdomen, which also makes it susceptible to injury. The renal blood flow is increased by 60%. The serum urea, nitrogen, and creatinine are reduced. Therefore, if you find a normal serum urea, nitrogen, and creatinine, this may reflect seriously compromised function in a pregnant woman. The diagram that you see on your right is showing the size of the uterus at the end of the first trimester, the second trimester, and the third trimester. So the uterus is an intrapelvic organ until the 12th week of gestation, when it is palpable at the symphysis pubis. It is then palpable at the level of the umbilicus at 20 to 22 weeks of amenorrhea, and at the costal margins at 34 to 36 weeks of amenorrhea. As the size of the uterus increases, the bowel is pushed towards the head, and as a result, it is somewhat protected in blunt trauma. However, the uterus, fetus, and placenta at a higher risk of injury. So in case of direct trauma to the anterior abdominal wall, or should I say blunt trauma, the uterus, fetus, and placenta are at a higher risk, whereas the gut is protected. But in case of penetrating injury to the upper abdomen, then there's a risk of multiple complex injuries to the gut. The placenta is vulnerable to shear forces at the utero-placental interface because it does not have contractile properties. The the complication that arises that comes with this is abruptio placenta, which is managed as an obstetric emergency for both the mother and the baby. The placental vasculature is sensitive to catecholamine stimulation. A decrease in maternal intravascular volume leads to increased uterine vascular resistance, which leads to reduced fetal oxygenation despite normal maternal vital signs. By the 7th month, the symphysis pubis widens by 4 to 8 millimeters. That word is supposed to be by, not to. The sacroiliac joint spaces increase, and these changes can cause confusion when interpreting pelvic x-rays. In the 3rd trimester, the fetal head usually descends into the pelvis, especially in prime gravidas. This means that in case of a pelvic fracture, it may result in skull fracture or serious intracranial injury to the fetus, especially if the head has already descended into the pelvis. Eclampsia, which is one of the complications of pregnancy, can mimic head injury because the presentation may be similar. However, you should always differentiate it, because eclampsia is when the patient presents with seizures that occur in the presence of hypertension. This patient may also have hyperreflexia, proteinuria, and peripheral edema. So it's very important to differentiate between eclampsia and head injury. So as we manage these patients, there are 3 goals that we should always put into consideration. The first is save the mother. The main cause of fetal death is maternal shock, and in order for the baby to survive, you must resuscitate the mother. Number 2, save the baby if possible. Number 3, because of the risk of abruptio placenta, it is advisable to admit even minor trauma for observation. The management involves the 2 surveys, the primary survey, which is the ABCDE, and the secondary survey. We're also going to briefly talk about diagnostic imaging and management of the obstetric complications that are commonly seen in an injured pregnant woman. So the components of the primary survey are similar to what is done in the non-pregnant population. So what is highlighted here are the key points that differ as a result of the physiologic changes and anatomical changes that occur during pregnancy. In these patients, there's an increased risk of failed intubation. To overcome this, always consider earlier intubation, use of a short laryngoscope, apply cricoid pressure. We talked about the changes in the gastrointestinal system. These patients should be managed as patients with a full stomach. Use a smaller ETT tube due to the laryngeal edema. These patients have an increased risk of aspiration, so consider use of a nasogastric tube if not intubated, or an orogastric tube if the patient is intubated. Do not hesitate to use a cervical collar for major trauma. Under breathing, administer high flow oxygen 100% for an SpO2 of less than 90 to 95%. We talked about hypoxia developing quite quickly in these patients. The ventilation volumes may need to be reduced due to the raised diaphragm. If a chest tube is indicated, it should be placed 1 to 2 intercostal spaces above the 5th intercostal space due to the raised diaphragm. Raise the head of the bed to reduce the weight of the pregnant uterus on the diaphragm. This is optional and it should be done only if it is safe. Under the circulation, always control obvious external hemorrhage. The pregnant patients who are 20 weeks of amenorrhea and above should be placed in the left lateral tilt. obtain large bore IV access and commence crystalloids and assess response to these fluids. This is because we said these mothers will not show any signs of shock until they've lost a minimum of around 1,200 to 1,500 mils of blood. And always remember that by the time the mother shows any signs of shock, then the fetus has been in shock for a longer period. Avoid the massive transfusion protocol should be initiated if the patient is unresponsive to crystalloids. Avoid vasopressors to restore maternal blood pressure. This is because of the risk of reduced uteroplacental flow. Thoroughly look for occult bleeding as maternal blood flow is maintained at the expense of the fetus. Conduct a focused abdominal sonography for trauma to assess for intra-abdominal hemorrhage. Evaluate the fetal heart rate. Transfer to the operating theater if indicated. There are times when you have to do an abdominal exam as an adjunct to the primary survey, and this will be to quickly rule out some of the complications like uterine rupture or abruptio placenta. Under disability, you need to do a rapid neurological evaluation. You could use the AVPU or the Glasgow Coma scale. This slide is showing the left lateral tilt. The first diagram that is on your left shows how the left lateral tilt is done. A wedge is placed beneath the right buttock of the patient and it raises the side of the patient by about 15 to 30 degrees, which means that it relieves compression of the gravid uterus on the inferior vena cava and the aorta. The second diagram that you see at the top right corner, is the left lateral tilt in case the patient has spinal injury or suspected spinal injury and immobilization is required. In such a case, it's not appropriate to put a wedge beneath the right buttock. So the entire board on which the patient is lying is raised by 15 to 30 degrees, and this will effectively relieve the aorta and the inferior vena cava from the pressure of the gravid uterus. And then the diagram at the bottom on the left is showing how to do manual displacement of the uterus, where the hands of the attendant or the health worker is placed on the right side of the patient's uterus, and manually the uterus is displaced towards the left. These three maneuvers are very life-saving maneuvers and should be done for all mothers who are 20 weeks of amenorrhea and above. So, in case of cardiac arrest, how should we manage these patients? Also, this slide is going to answer the question about perimortem cesarean section, whether it has a role in the management of these patients, that's in case of a cardiac arrest, and it's also briefly going to highlight the role of emergency cesarean section. So in case of a cardiac arrest in a pregnant woman, the management is the same as the non-pregnant population. What differs is position the patient in the left lateral position. So all the maneuvers that are done as you're resuscitating this patient should be done with the patient in the left lateral position. Always note that efficiency of CPR in maintaining organ perfusion is reduced by aortocaval compression. So there is what is called a perimortem cesarean section. It is a cesarean section that is initiated after CPR is commenced. It is done for gestations above 20 weeks of amenorrhea, and it is performed after 4 minutes of non-response to effective CPR. There is no need to transfer the patient to theater. There is no need to stop the resuscitation to do the procedure. So the CPR is continued during and after the procedure. Emergency cesarean section has a limited role in the management of these patients, and is primarily done in case the mother is unstable or is not responding to interventions. The secondary survey is done after stabilization of the patient, that is after the primary survey. So I'm only going to highlight the obstetric history and I'll move on to the exam. So in the obstetric history, always ascertain the exact gestation age or estimate the gestation age. Ask for history of prenatal care. You can get it from the records or from the history. Always ascertain whether there is history of vaginal bleeding, and also ascertain the previous pregnancy complications, as these could alter the management that is being offered to this patient. Under the physical exam, this is done from head to toe, just as it is done in the non-pregnant patients. However, under the obstetric exam, it's important to assess for serial fundal height measurements, which are seen to increase in case of concealed abruptio placenta, assess for the uterine tone, assess for uterine contractions, which could indicate labor, assess for rigidity and tenderness, assess for palpable fetal parts, which could indicate a ruptured uterus. It's important to do continuous CTG for mothers who have suffered major trauma above 24 weeks of amenorrhea. For the pelvic/vaginal exam, a sterile speculum exam is used, and you evaluate for ruptured uterus to rule out premature rupture of membranes, bleeding to rule out abruptio placenta or uterine rupture, cervical effacement to rule out labor and cord prolapse. A rectal exam could also be done for spinal cord damage or local trauma. Consider use of a urinary catheter or urinary catheter insertion in case the patient is unconscious, is immobilized, or in case there is a need to monitor the urine output. This slide is going to look at the role of diagnostic imaging in the injured pregnant woman. The risks of radiation to the fetus are small compared to the risk of delayed or missed diagnosis of trauma. This is because diagnostic imaging is usually shunned or avoided because of the risk, or it is associated with teratogenicity or the fear of teratogenicity. However, X-rays of the extremities and the head, mammography, CT scan of the head, neck and chest and abdomen without contrast are associated with negligible fetal radiation doses. The risk to the fetus is negligible if the exposure is less than 5 rads, and the risk increases at more than 15 rads of exposure. These X-rays that we commonly do of the extremities and heads are associated with less than 5 rads of exposure. So it is actually better to do the diagnostic imaging and avoid missing a diagnosis of trauma. However, in case a CT scan with iodinated contrast is required, it's preferable to perform a single CT with iodinated contrast than to perform multiple suboptimal studies without contrast. Gadolinium, however, is not recommended unless benefit clearly outweighs the risk because it is associated with teratogenicity to the fetus. The paralytic drugs that are used for anesthesia do not cross the placenta. Actually, most of the drugs that are used in anesthesia with reasonable certainty are noted to be safe in pregnancy. And here we're specifically looking at the inhalation anesthetics, the local anesthetics, the muscle relaxants, the narcotics, and the benzodiazepines. The common complications that a pregnant woman who has suffered trauma will experience are fetal maternal hemorrhage, preterm labor, abruptio placenta, uterine rupture, amniotic fluid embolism, disseminated intravascular coagulopathy, pelvic fractures with severe blood loss, and some may suffer minor trauma. I indicated eclampsia at the bottom just to remind us that it should always be differentiated from a head injury because the symptoms may be similar. This slide is going to talk about the symptoms, signs and symptoms of each of the complications and the recommended management. So mothers who have gotten or suffered from fetal-maternal hemorrhage will present with reduced fetal movements. They'll present with signs of fetal distress. This will be seen as a sinusoidal pattern on CTG. They may present with intrauterine fetal death, or the mother may present with a transfusion reaction. A Kleoha test is done for all rhesus D negative mothers who are 12 weeks of amenorrhea and above. And anti-D, that's rhesus D immunoglobulin, at a dose of 652 international units, protects against 6 mils of fetal red blood cells that have been transfused into the maternal circulation. So the test helps you quantify the dose that is supposed to be given to the mother. That is supposed to be given to the mother. It's important to do an obstetric ultrasound scan to ascertain fetal viability, and in case the fetus is viable, it's very important to initiate a continuous CTG. If a mother presents with preterm labor, they will present with uterine contractions, which they are said to be 4 contractions per hour or more. They will have cervical dilatation. They may present with vaginal bleeding or a change in the vaginal discharge. These mothers are managed with corticosteroids, tocolysis, and they should always be managed in consultation with the obstetric team. Mothers with abruptio placenta present with abdominal pain, a woody hard abdomen, which we also call a rigid abdomen. They may have uterine contractions. They may have vaginal bleeding. They may have an expanding final height in case of concealed abruptio placenta. They may present with features of fetal compromise in case the fetus is still alive. They may present with maternal hemodynamic instability, or they may be asymptomatic in case the placental abruption is mild. It's important to do an obstetric ultrasound scan to ascertain fetal viability. CTG is usually done, especially if the fetus is viable. It's important to do the labs, that is the CBC, the CBC, blood group and cross match, and it's important to transfuse with blood products because these patients lose a lot of blood. Consider fetal maternal hemorrhage for all mothers who are rhesus D negative. Corticosteroids should be given if the mother is between 24 and 34 weeks of amenorrhea, and these mothers should be delivered as an emergency. There's no room for conservative management, and they should be monitored for signs of DIC, which is a complication of abruptio placenta. Mothers with a uterine rupture present with intrauterine fetal death and easily palpable fetal parts. However, in case the baby or the fetus is still alive, they will present with CTG abnormalities. These mothers also have a positive that is focused abdominal sonography for trauma tests. They have uterine tenderness. They may have vaginal bleeding, and some may present in shock. Prompt hemodynamic resuscitation with blood products is very important in these patients. An emergency laparotomy is done, and the uterus is either repaired or a hysterectomy is done in case the uterus is irreparable. Patients with amniotic fluid embolism present with maternal hypotension, massive hemorrhage. They may present with seizures, respiratory distress, fetal distress, DIC, or a cardiac arrest. Airway management is very important in these patients. Provision of high flow oxygen, provision of blood products, that is fresh frozen plasma, cryoprecipitate, and platelets, and they should be managed by a multidisciplinary team. Mothers who present with disseminated intravascular coagulopathy may have clinically detectable microvascular bleeding. They may have abnormal labs, that's the platelet count, PTINR, APTT, fibrinogen levels, and fibrinogen levels that are less than 2.5 grams per liter. These patients should be managed aggressively by a multidisciplinary team. The underlying cause should be treated, and if undelivered, the baby and the placenta should be delivered. So in summary, it's always important to remember that there are anatomical and physiological changes that have occurred during pregnancy. The trauma management principles remain the same, that is ABCDE. Management of the mother comes first. Resuscitation of the mother is also resuscitation of the fetus. A mother may require the baby to be delivered as part of her resuscitation. Always remember the aortic cavo compression and the left lateral tilt. Uterine rupture, abruption placenta, and fracture of the femur can all cause massive hemorrhage. So let's move on to intimate partner violence and trauma. Intimate partner violence is the major cause of injury to women during cohabitation and marriage. It exists all around the world, regardless of ethnic background, cultural influences, or socioeconomic status. The incidence of IPV is increased during pregnancy. 17% of injured pregnant patients experience trauma inflicted by another person, and 60% of those patients experience repeated episodes of intimate partner violence. Some of the indicators of intimate partner violence include injuries inconsistent with a stated history, diminished self-image, depression, suicidal attempts, self-abuse, frequent emergency department or doctor visits, symptoms suggestive of substance abuse, self-blame for injuries, and some of them may come with a partner who insists on being present for the interview and exam and monopolizes the discussion. Most of the time, this is the perpetrator or the person responsible for causing the intimate partner violence. These screening questions, when asked in a non-judgmental manner, can identify 65 to 70% of victims of intimate partner violence. You could ask, have you been kicked, hit, punched, or otherwise hurt by someone in the past year? If so, by whom? Do you feel safe in your current relationship? Is there a partner from a previous relationship who is making you feel unsafe? Many times, if these questions are asked, these ladies or these patients will open up, especially if the environment is a non-judgmental environment. So I leave you with a case that you'll answer in your free time of a 25-year-old female who appears to be in her 3rd trimester of pregnancy, who is brought into the emergency room after being struck by a car while crossing the street. What are the initial steps in the management of this patient? Always remember, as you answer this question, that there are physiological and anatomical changes that have occurred. Always remember that the management principles are the same, ABCDE. Management of the mother is ultimate, resuscitation of the mother is ultimately resuscitation of the fetus, so put the mother first. Always remember the left lateral tilt, and always remember that these mothers are prone to complications, that is premature labor, abruption placenta, and pelvic fractures. These are the resources that were used to make the presentation. I hope that after this presentation, management of pregnant mothers who have suffered trauma will be much easier for you in your practice. Thank you for listening and have a good day.